Good afternoon to all who have joined the final grand rounds of this year, and this one is a biggie. My name is Sadiq Anwar. I'm a consultant physician at Sheikh Shahbood Medical City. Handheld point-of-care ultrasound is a disruptive technology which will help us radically transform how we deliver bedside clinical care. To talk about this, it's my great honor and pleasure to invite my friend and collaborator, Dr. Abhilash Koratala from Medical College of Wisconsin, from a warm and sunny Milwaukee, while we are in peak winter here in Abu Dhabi. Abhilash is an assistant professor of medicine and serves as the director of clinical imaging for nephrology at Medical College of Wisconsin. Abhilash is one of the new generation of innovative and path-breaking nephrologists who are making nephrology cool again. He's a recognized leader in our field and is doing many pioneering work, including the use of social media to democratize medical education. He has an award-winning website, nephropocus.com, and he's a superstar educator, and thousands follow him on Twitter and Instagram, where he's on as Nephropocus. He's like the BTS of nephrology world, and I too follow him religiously. But I would say his main accomplishment is how he and few others have revolutionized the way we approach bedside fluid assessment with point-of-care ultrasound. The title of his presentation is Point-of-Care Ultrasound, Assisted Physical Examination is the Future, and the Future is Now. I'm sure you will find his talk inspiring, and I welcome Abhilash to SSMC and Abu Dhabi. Thank you all.
Thank you. Thanks for the kind introduction, Dr. Anwar. Yeah, without much delay, we'll just go into the presentation. And I have nothing to disclose. This is the roadmap of the presentation. First, I'll discuss a few myths and facts surrounding POCUS or point-of-care ultrasonography. Then let's quickly talk about a few cases, some real life cases from my practice, and a couple of slides on program development for new programs looking to incorporate POCUS. And hopefully we'll leave a few minutes for questions. And the myths and facts. First of all, why do you, meaning internal medicine doctor or a clinician, want to do ultrasound? It's radiologist territory. That's a common question that comes up when we talk about ultrasound. So first of all, so we need to understand what point-of-care ultrasound is. It is the ultrasonography performed at the patient's bedside, that is at the point of care by the treating clinician to answer focused questions. And answering these questions will either provide the diagnosis or narrow the differential diagnosis, or you can also use point-of-care ultrasound to guide a bedside procedure. So what are some examples of these focused questions? These are the questions you have in mind after a routine history and conventional physical examination. And does this patient with AKI have hydronephrosis? So obviously the conventional physical examination cannot show you whether the patient has hydronephrosis or not. And does my patient with unexplained hypotension have pericardial effusion, or is the LV systolic function looking okay? Does this patient with abdominal pain have gallstones, or is this patient short of breath because of pleural effusion or pulmonary edema, or in the right clinical context, is there a pneumonia going on in the lungs? So all these are examples of focused questions. And POCUS, or the ability of the clinician to perform ultrasound, expedite patient care. For example, you're in the outpatient dialysis unit, say from nephrologist perspective, or you're in the internal medicine outpatient clinic. You have a patient who you're suspecting pericardial effusion, and then you would make an appointment, and the patient goes to the cardiology department, the technician performs a scan, the cardiologist reports it. So it might take a few days depending upon when the patient is getting the appointment. On the other hand, if the clinician is able to perform POCUS, you get the answer right away in few minutes. These days we have these handheld ultrasound machines, which are okay. Which provide adequate image quality to answer simple questions. So in that case, you just got your answer right away. And POCUS is emerging as an enhancement, or in fact, a component of physical examination. So insonation, or utilizing ultrasound to perform bedside diagnosis, is a component of physical examination in addition to inspection, palpation, percussion, and auscultation. And these are all the point of care devices we are familiar with, right? We have a reflex hammer, flashlight, tape, tuning fork, stethoscope, all these things are bedside diagnostic tools. And the sonoscope, or the point of care ultrasonography, is the latest tool added to our toolbox. And now somebody comes and says, I'm super good with my physical examination skills. Why do I need a diagnostic aid? I'm good with my stethoscope. And this has been looked at. Here is a 20-year-old study where they looked at the auscultation skills of medical residents from USA, UK, and Canada. They made them listen to 12 pre-recorded cardiac events, which were considered important by their program directors. And then they took a multiple choice questionnaire. And as you can see, the performance of all these trainees, whether USA or UK or Canada, they performed very poorly on this test. So our physical examination skills are reducing. I just put this up as one example, but there are several papers examining the physical examination skills of physicians and showed that they are declining progressively. And in fact, there is one study which shows that our physical examination skills do not improve after MS3 year, that is third year medical student year. And you can only imagine when you are in the telemetry ward or ICU or the dialysis unit where all these machines are beeping, you can imagine that the sensitivity of your auscultation is going to go down. And not only our physical examination skills are declining, but the inherent sensitivity of physical examination itself is low. For example, look at this study, which was done in 50 chronic heart failure patients with fairly low ejection fraction and high pulmonary capillary wedge pressure of 22. And this was study published like 30 years ago. What they found was the sensitivity of Rales, edema, and elevated mean jugular venous pressure was only 58% to detect this high pulmonary capillary wedge pressure, though the sensitivity was fine. Specificity was fine, meaning most of these classic signs were described when late presentations of diseases were common. But in reality, we want to diagnose these conditions sooner so that we can treat them sooner and hopefully change the outcome. And that was in the heart failure setting. And there is this study in the ICU setting where they examined about 1,000 ICU patients. Half of them were mechanically ventilated, and they compared the sensitivity of auscultation to detect crepitations or rhonchi with lung ultrasound. And this lung ultrasound was performed by senior medical students and junior residents who were trained by cardiologist intensivists. So when I say lung ultrasound, in general, ultrasound cannot show you the lung tissue when lung is filled with air. So this is how lung ultrasound looks like on the left side. So this bright line is the pleural line, and these are rib shadows. So that means we are looking at one rib intercostal space. And here, when the lung is filled with air, you see horizontal reflections of pleural line, which are called A lines. That means A lines represent air in the lung. And when there is interstitial edema or interstitial thickening, instead of seeing horizontal lines, you see vertical lines arising from the pleural line. These are called B lines. The more is the number of B lines, the more is the degree of severity of pulmonary congestion or pulmonary edema. So with that, we'll go back and see what this study showed. So auscultation was normal in half of the patients who had pulmonary edema on lung ultrasound. And obviously the sensitivity of abnormal auscultation findings was only about 50%, and specificity was only about 74% to detect clinically significant pulmonary congestion that was otherwise detected by the lung ultrasound. And here is the study from very sick patients, relatively low sample size of 32 patients, but they all had ARDS, and they also had 10 healthy controls for comparison. This was a study published in 2004 by Dr. Lichtenstein and team. He's considered as father of lung ultrasound. And what they found was in these patients, this diagnostic accuracy of ultrasound, that is lung ultrasound, was substantially higher than auscultation and even chest X-ray to detect pleural effusion, alveolar consolidation, and alveolar interstitial syndrome. So we still sometimes get daily chest X-rays on ICU patients, and which can essentially be abolished if you are proficient in point of care ultrasound. And coming to dialysis patients, there was one study which showed that the combined sensitivity of lung crackles and peripheral edema was only 13% to detect clinically significant pulmonary congestion that was detected on lung ultrasound. And there was this meta-analysis in medical patients comparing physical examination and focused cardiac ultrasound, or FOCUS. What they found was the sensitivity of auscultation to detect LV dysfunction was only 43%, while that of focused echocardiogram was 84%. And similarly, for detection of valvular disease, auscultation was only 46% sensitive, while focused cardiac ultrasound was 94% sensitive. So there is a lot of evidence showing that point of care ultrasonography increases sensitivity of your conventional physical examination, that is diagnostic accuracy at the bedside. And there was this fun little experiment where they compared the diagnostic accuracy of 5 board certified cardiologists using stethoscope versus 2 first-year medical students with only 18 hours training in focused echocardiography, or FOCUS. And they made them do this focused echocardiography. All these had about 239 abnormal findings in 61 studies. And these medical students, first-year medical students with very limited training, were able to identify correctly the 75% of the pathologies, while board-certified cardiologists using stethoscope were able to identify only 49%. So that means even for experienced user or less experienced user, adding point of care ultrasonography increases the diagnostic accuracy. Okay, so you made enough fun of my physical examination skills. And so you're saying you detect asymptomatic pulmonary congestion. So, but how is it clinically relevant? That's a fair question, right? So you're saying the patient might not be symptomatic, and does this matter? So there was this nice study in heart failure patients. So they looked at 123 adults who were being discharged from a heart failure related hospital admission. And 41 out of those 123 had pulmonary congestion only on POCUS, while 59 of them did not have either clinical congestion, that is on conventional physical examination, or on POCUS. So compared to people who did not have any kind of congestion, whether on POCUS or whether on clinical examination, people with subclinical congestion had significantly higher primary outcome, that is the combined endpoint of rehospitalization, unexpected heart failure visits, or death during 6-month follow-up, and that was significant. Similarly, the risk of heart failure readmissions was substantially higher in patients who had B lines on lung ultrasound at discharge, and these patients were completely asymptomatic. And similarly, in dialysis patients, this is a large cohort of about 400 hemodialysis patients, and they categorize them by the number of B lines. So you can sono-auscultate or look at different intercostal space in the lung. The more symptomatic is the patient, the less zones you can auscultate to find the etiology. Usually these dialysis patients are not so symptomatic, so you auscultate more zones and you count the number of B lines. So people who had more than 60 B lines had significantly increased all-cause mortality compared to those who had 15 to 60 B lines compared to those who had less than 15 B lines. Same is the case with fatal and non-fatal cardiac events. And the mean follow-up in this study was about 2.1 years, which is fairly high. So asymptomatic congestion does portend prognostic significance. Okay, now another person comes and says we are not as good as radiologists, so we'll end up ordering further imaging tests anyways. They looked at that too. Here is an example, Italian cohort impact study in close to 2,000 patients from hospital ward, general practice, and gastrointestinal outpatient clinic. In this study, like a lot of physicians, more than 100 physicians, performed ultrasound using GEV scan, a handheld ultrasound device, to answer some common clinical questions encountered in internal medicine practice, including ascites, pleural effusion, gallstones, and so on. And what they found was further diagnostic testing after POCUS was deemed unnecessary in 63% of the patients. And false negatives on POCUS were only 5%. And in patients who were undergoing further tests, the sensitivity of POCUS was shown to be 91%, which is very high. And there is another study in internal medicine ward, kind of a geriatric ward in another Italian single center study, where they looked at about 500 patients. Half of them got POCUS guided treatment and half of them got usual care. And people who got POCUS guided care, that group had very less number of diagnostic imaging tests ordered. That means less exposure to unnecessary radiation compared to people who had POCUS. And the ultrasound machines are expensive and they are so big, I cannot drag that machine to every ward or floor I go. But that's not true, because ultrasound machines exist in different shapes and sizes depending upon what functionality you need. There are highly sophisticated big machines which cost like several $100,000. And there are laptop-based machines which cost about $40,000 to $50,000. And you have these days handheld machines which you can connect to tablet or your phone and carry in your pocket. Or you have even smaller devices which come with their own display device and that can be carried in the coat pocket. And this is me here. This is my big machine with all the probes. It has all the functionalities that we need, including spectral Doppler. While in my hand here is a small Bluetooth handheld ultrasound device. And I'm not saying both are equal. And the big machine is like a big BMW car versus the small handheld machines are like, you know, the economy cars, but they do the job. It depends upon what focused clinical questions you want to answer using these machines. So another person comes and says, you're not a cardiologist and want to scan the heart. You should stay in your limits. So the real question is, who owns POCUS? Right, this is American Medical Association policy. It was made in 1999, like more than 20 years ago. They said ultrasound imaging is within the scope of practice of appropriately trained physicians, irrespective of the specialty. It's just that the hospital system, when providing credentials, should take into consideration the level of training the physician has got and what are the requirements of that physician's particular specialty, and then give them the hospital credentials. So essentially, POCUS is within the scope of everybody who uses a stethoscope and performs physical examination. And if listening to the heart is within your scope, you can perform POCUS too, that is a focused cardiac ultrasound, assuming you have proper training. That's what is important. And a fun fact is the stethoscope is not really a scope, because scope means to view. And with stethoscope, you're only listening to the heart. So it should ideally be called stethophone. So the real scope is the sonoscope. And what are the uses of stethoscope in the POCUS era is to detect wheeze, rub. Obviously, these cannot be detected using ultrasound. And when you forget your reflex hammer, you can use the bell of the stethoscope as a replacement for a reflex hammer. And I think the real effect is it provides placebo effect, because stethoscope has become a symbol of physicians or symbol of healthcare professional. So in that sense, patients just feel the placebo effect when you carry a stethoscope, whether you are able to listen to their lungs properly or not, it doesn't matter. So what are the levels of POCUS? POCUS, obviously it's a long-term thing. You don't get highly skilled in POCUS in one day. So POCUS can be divided into basic skills and advanced skills, where you ask simple focused questions in basic POCUS, and you ask more complex and detailed questions such as hemodynamic assessment in advanced POCUS. And the skill level required for basic POCUS is low, while for advanced POCUS it's high. And basic POCUS does not typically include spectral Doppler applications, while advanced POCUS does. Spectral Doppler is the Doppler, the tracing that you get when you are measuring blood flow velocities or heart muscle movements. So it is essentially a little more advanced Doppler application. And this is how the scope of internal medicine point of care ultrasound looks like. You can do a multi-organ point of care ultrasound for diagnostic purposes and also procedural guidance. The red lines indicate procedural guidance. So in the head and neck, you do ocular ultrasound. You can know if the patient with the malignant hypertension has any papilledema, or you can do carotid ultrasound, examine the sinuses in your clinic, examine the thyroid right away in your clinic patient. In the lungs, you look for pulmonary edema, pleural effusion, pneumothorax, pneumonia. You can use POCUS to guide thoracentesis when needed. And in the abdomen, you look for ascites. You can drain ascites. Look for gallstones, splenomegaly, and so on. And kidneys, you look for hydronephrosis, kidney size. You can do gonadal ultrasound, look for testicular torsion or ovarian cysts depending on the clinical context. And you can do soft tissue ultrasound. You look at cellulitis, abscess, hematoma, lymph nodes. And when you find an abscess, you can use ultrasound to guide incision and drainage. In the heart, you look at how is the gross pump function, if the patient has any pericardial effusion, did any of the chambers grossly enlarged, is there any valvular dysfunction, and if there is significant pericardial effusion, you can also use to guide pericardiocentesis. You can do musculoskeletal POCUS to examine joint effusion and do arthrocentesis if needed, and to look at tendon and ligament pathology. And all these things you can do in your clinic or in the inpatient setting. Even before you get other further imaging such as MRI or CT scan. And you can look for deep vein thrombosis in a patient with shortness of breath and you are suspecting pulmonary embolism. And you can use ultrasound to guide peripheral venous catheter or arterial catheter placement. And here is an example of bedside hemodynamic assessment, which requires advanced skills, but lets you examine the whole hemodynamic circuit, which is really the ideal way of guiding fluid therapy or diuretic therapy or fluid removal strategy in sick patients. So I'll just walk you through this very quickly. And when you look at the left ventricular outflow tract, you can assess the stroke volume at the bedside. Then you go back and you're looking at the flow through the mitral valve and the pulmonary vein. Then you get an idea of the left ventricular filling pressures. Then you go backwards and assess the extravascular lung water by doing lung ultrasound. And then you go further backwards and you do right ventricular outflow tract Doppler and tricuspid inflow Doppler so that you get a better idea of the right heart pressures. And then you go back and assess the inferior vena cava. That's another good indicator of right atrial pressure. And further down with from IVC, the right atrial pressure is going to be transmitted to the organs, leading to congestive organ injury. Those things you can detect by doing hepatic vein Doppler, portal vein Doppler, and renal parenchymal vein Doppler. And also you can look at ascites in shortness of breath patients. You can do deep vein thrombosis evaluation. So this is how a complete hemodynamic assessment looks like. So an experienced physician comes and thinks, I'm very experienced and I'm a well-known expert in my field of research, and I don't need to bother with POCUS. POCUS is for young physicians. It's a shiny new toy. That's what some people think, but that's not true. And the medical education is changing, and POCUS is being integrated into medical curriculum, undergraduate medical curriculum, from the first year itself. And here on the left is a famous painting of Rembrandt from 1632. In this gentleman here is Dr. Nicholas Taub, who is teaching anatomy to medical students by dissecting a human body. In the 21st century, we are teaching anatomy by using ultrasound, and not only anatomy, we are teaching anatomy to medical students using ultrasound. We are teaching physiology, and in the clinical years, we are teaching how to integrate anatomy and physiology and assess pathophysiology at the bedside using ultrasound. And this was the latest survey, published I think a few months ago, but this was originally 2019 survey of medical schools in the United States. And out of the 65% respondents, 72% of medical schools have a formal ultrasound curriculum. And of those schools, 83.5% had a mandatory ultrasound training. It's not just some elective training. And like most of them have actually incorporated ultrasound in basic science courses, not even clinical courses. And emergency medicine physicians constitute about half of the course directors. And in US, I think in most part of the world, it's emergency medicine who actually started doing POCUS and took it to the next level. And in US, most of the emergency medicine residency programs have 1 year point of care ultrasound fellowship. And also, like, if you're graduating from a emergency medicine residency, you are supposed to have competency in point of care ultrasound. And recently, UC Irvine Medical School, this is one of the medical schools in US, gave this handheld ultrasound device to all the medical students, all the incoming medical students. Generally, what they do is they do something called white coat ceremony. They give stethoscopes to incoming medical students. And in addition to stethoscopes, these people give handheld ultrasound devices. And more schools are joining this bandwagon. And this is another medical school in Philadelphia, which gave handheld ultrasound devices to all the medical students. And eventually it's going to lead to role reversal. And if the resident or these graduating medical students, when they graduate from medical school and residencies, they're going to be better trained than practicing physicians who fail to incorporate or learn POCUS. And they say, for these students, it's like physical examination, right? So the student or the resident is saying, hey doc, I see some dynamic air bronchograms in this patient, which means dynamic air bronchograms means the patient probably has pneumonia. But the senior physician has no idea what that means. And eventually he or she is going to ask for a chest X-ray, ignoring the more sensitive tool that is point of care ultrasound. And this is another common criticism of POCUS, and people say POCUS is operator dependent. And in reality, it has no meaning, because operator dependency is not about point of care ultrasound. It is an inherent limitation of ultrasonography itself as a diagnostic modality. So compared to CT scan or MRI, which have standard image acquisition and do not depend upon the technician or the operator skills, or for the most part on patient's body habitus, the ultrasound in that sense is more dependent on the operator. But in terms of POCUS, it does not apply, because everything we do is operator dependent, right? From history taking, physical examination, or communicating with our patients, everything we do in routine clinical care is operator dependent. That's why there are good doctors and bad doctors. So all we need is good training in ultrasound rather than just blaming the operator dependent on nature of the ultrasound and just ignoring it. And this is another common question or concern. What if I miss some finding and get sued, right? So because we are not used to doing ultrasound. Again, the key is really emphasis on proper training and longitudinal training rather than just staying away from a useful modality just because of the fear of getting sued. There is data for this too. And I said, like, in US, emergency medicine physicians have been doing POCUS for a long time, right? So in this study published in 2012, they looked at 20-year-old data and they reviewed 659 pertinent lawsuits. And there was only one case related to POCUS. And even that was because of failure to perform POCUS in a timely manner and not because of wrong findings or wrong interpretation. And they also looked at 25-year-old data if there are any cases against neonatologists and pediatric subspecialists using POCUS. Out of 468 cases reviewed, there were only 2 related to point of care ultrasound. Even those 2 were just because of failure to perform a diagnostic test, POCUS being one of them. So really nothing. And they also looked at lawsuits against internal medicine, pediatrics, family medicine, and critical care physicians practicing POCUS. And they reviewed 131 cases, but there were no lawsuits because of failure to interpret the POCUS findings properly. So it's baseless fear. And another common concern is, like, POCUS takes away business from radiology and cardiology, hence they won't allow us to do. That's not really true for several reasons. One thing is, when we say POCUS, we are using it as a component of physical examination, right? So you don't call radiologist or cardiologist to do physical examination for you. So most of these things, especially in internal medicine practice, are for follow-up. You do a lung ultrasound initially in a patient admitted for heart failure exacerbation. You follow them up the next day, the day after that, on the day of discharge. Normally, you won't call anybody to do that thing. These are just additional diagnostic bedside aid rather than you're calling somebody to help you every day. And anyways, like radiology doesn't do lung ultrasound anyways, right? And radiology also doesn't typically do venous congestion assessment. Of course, they do Doppler of the abdominal organs if needed, but for the purpose of congestion and monitoring acute kidney injury, we don't ask radiology come do every day. And radiology has better things to do. They have CTs, MRIs, and other things to do. They have interventional radiology, so they are not going to bother about few ultrasound scans that you're going to take away from them. It's just a misconception or misinformation that some people might have. But I never really encountered any problem from radiology. I've been in 2 different institutions, and radiology was the least bothered thing, bothered specialty when you want to do POCUS. And cardiologists, first of all, cardiologists don't do POCUS. When I say don't do POCUS, at least as of at least in the US, the ultrasound is performed by the ultrasound technician, not cardiologist. So that itself tells you that it is not POCUS. POCUS is ultrasound performed by the clinician to answer just one question. And also, if we are not trying to take away whole echocardiography. Echocardiography is complex. It takes about 45 minutes to 1 hour to perform a complete echocardiographic exam. It uses pre-specified measurements and stuff. So we are not trying to do that in the point of care setting. And most physicians would just restrict to very basic stuff such as pericardial effusion, gross chamber enlargement, or gross valve leakage. Also, imaging is evolving. There are other things for cardiologists to do, and there is 3D echo, 4D echo, strain assessments, and so on. So cardiologists don't bother about your few echoes. Actually, cardiology fellows will be happy that you are not calling them for every little thing. And some people might say, I will adopt POCUS only if it improves mortality. First of all, nobody asked this question about stethoscope, right? Does stethoscope using improve mortality? No. So first of all, what to expect from a point of care diagnostic aid is, does this diagnostic aid helps you better diagnose something clinically relevant? And is it better than the conventional method that you are currently using? Yes, of course, yes. POCUS does, and I showed you several studies, and there are more studies. And is it a safe modality? Of course, it does not involve radiation, and for all practical purposes, there are no known harms of diagnostic ultrasound exposure when you use it judiciously. So it's safe. And does it change the decision-making process? Yes, there are several data showing that POCUS changes the decision-making process, the choice of treatment, and enhances confidence of the doctor treating the patients. Obviously, if you make better diagnosis and you're more informed diagnosis, the doctor will be more confident. And does it improve any patient-relevant outcomes? So does it change the disease course and the risk of death or quality of life or healthcare cost burden or satisfaction? Or does it help patients to understand better about their medical condition? There are already data showing POCUS does some of these, but when it comes to real mortality benefit will only occur when the right test is performed, which is coupled with the right treatment. Because the test, doing some test or diagnosing something will not necessarily change the course of the disease unless you have a treatment. I say use ultrasound to evaluate fluid overload in a patient with cirrhosis or hepatorenal syndrome, just to avoid indiscriminate use of albumin. I demonstrate B lines in the lung, so I say don't give albumin. But does that improve mortality? Probably not, because HRS or hepatorenal syndrome has high mortality, so it might not. So unless you couple it with the right treatment, it's not going to change mortality. Okay, very good. I think we're doing good on time. So these are the common some myths and realities associated with POCUS. So let's briefly talk about some real life examples that I saw in my practice. We have a middle-aged man with low ejection fraction of about 20% who was admitted for non-healing ulcer, possibly requiring amputation, some leg ulcer. And the baseline serum creatinine was 1.7 to 2 milligram per deciliter. He had some CKD, and it was slightly up at presentation at 2.4. And the admitting team has resumed home dose of bumetanide. And 2 days later, the serum creatinine has progressively worsened. And the internal medicine physician looked at the intake and output data. It seems like the patient is negative, and the documented weight is about 8 kg down. That's strange. But the patient was moved from one unit to the other unit, so they were using a different weighing machine. And they did FE urea. They did not do FE sodium or fractional excretion of sodium because the patient is on diuretics. They looked at a fractional excretion of urea, which was 18%, which is suggestive of pre-renal etiology. And the internal medicine notes on that day said respiratory, there is bilateral air entry, it's clear to auscultation, and there are no wheezing, rhonchi, or rales, and the patient was breathing comfortably on room air. So the question for this physician was whether the patient is over-diuresed, especially in the setting of low FE urea. But so why are we even asking this question? So when you have low FE urea, the patient can be hypervolemic and have FE urea, because when you are hypervolemic also, kidney tries to retain sodium and water and urea. And when you are hypovolemic also, the kidney tries to conserve all these things, because kidney behaves the same way, whether it's congestion or volume depletion. And again, why are we talking about congestion? Because organ perfusion pressure, or maintaining organ perfusion, is our ultimate goal when it comes to AKI or pre-renal AKI, or more precisely hemodynamic AKI. So organ perfusion pressure is the difference between inflow and outflow. So inflow is mean arterial pressure, and outflow is the afterload of the kidney, that is central venous pressure. Whatever resistance is offered to the venous flow from the kidney, that you can consider as afterload or outflow pressure. So if you have high CVP, that's going to reduce the organ perfusion pressure, as does low inflow pressure or low MAP. So it's important to differentiate between congestive state versus volume depletion state. But in most of the patients who are admitted to the hospital, congestion is more common than volume depletion. And so we then did the physical examination, that is point of care ultrasound. So looked at the heart, we know the patient's ejection fraction is already low. This is the 4-chamber view of the heart. Here is the LV, it barely contracts, consistent with known low ejection fraction. Then looked at the inferior vena cava, this anechoic or black thing going into this right atrium here is the inferior vena cava. So essentially inferior vena cava is a tube that goes into the right atrium. So it's like a pressure gauze for the right atrium. If the right atrial pressure is high, inferior vena cava is going to be big and dilated and minimally collapses with inspiration. Because normally during inspiration, right atrial pressure reduces and inferior vena cava collapses. And in here you can see that the IVC is big, that is more than 2 centimeters, and it is moving with respiration up and down, but it is not at all collapsing. So this IVC is plethoric and indicating high right atrial pressure. That means the CVP is high. And then we also did a portal vein Doppler. So what does it mean? Why did we do this? So just a background about it is, so that's a component of VEXUS. VEXUS means venous excess ultrasound grading system. Remember when I showed you the hemodynamic circuit, I said you have a right atrium here. When the right atrial pressure is increased, the first inferior vena cava is going to dilate. And then with the further backward transmission of the right atrial pressure, you have flow alteration in the hepatic vein, portal vein, and renal vein, or more precisely renal parenchymal vein. So VEXUS, or venous excess ultrasound grading system, evaluates hepatic vein Doppler, portal vein Doppler, and intrarenal vein Doppler to see how the blood is flowing in those veins, in addition to inferior vena cava ultrasound, to identify organ congestion, or tries to quantify venous congestion. And why IVC alone is not enough is because this is a recent study which looked at the VEXUS scoring, and they found that the probability of having acute kidney injury when a person has positive test, when you use the combined scoring, that is IVC and hepatic vein, portal vein, and renal vein Doppler, is much higher compared to when you use the IVC alone. So VEXUS scoring, or this combined scoring, will increase your ability to detect organ injury. And So how does hepatic vein Doppler look like? So normal hepatic vein Doppler is just a replica of central venous pressure waveform. If you remember central venous pressure waveform, you have A wave, X descent and Y descent. So similarly in hepatic vein, X descent we call S wave, which means it's occurring during systole, and the Y descent you call it D wave, which means it's occurring during diastole. And this is the flow towards the heart. So that means blood is flowing towards the heart during systole and diastole in a wavy pattern. That's normal hepatic vein waveform, which looks like exactly like the central venous waveform. With increasing right atrial pressure, there is more resistance offered to blood flow or the venous return during systole. You can better imagine this way if you imagine tricuspid regurgitation. What happens with tricuspid regurgitation during ventricular systole? There is a tricuspid regurgitant jet going backwards, offering resistance to the venous return. So SVO becomes smaller and smaller with increasing right atrial pressure. Eventually, all the above the baseline waveforms fuse and forms a single S wave. Only the D wave or the diastolic wave remains below the baseline. And that's called D only pattern, which indicates severe congestion. That means there is venous return only during diastole. And you need to have always EKG guidance when you're doing hepatic vein waveform as much as possible, because that will help you identify which is S wave and which is D wave. Otherwise, it can get confusing at times. So in EKG, the wave that follows QRS complex on EKG is the S wave, and the wave that follows the T wave is the D wave or the diastolic wave. And portal vein waveform, on the other hand, normally it's continuous because portal system is separated from the main venous stream by hepatic sinusoids. So it doesn't have a normal S and D wavy pattern, but it's more continuous. And with increasing right atrial pressure, it becomes more and more pulsatile, and more than 50% pulsatile is called severely. It indicates severely elevated right atrial pressure, and with further elevations in right atrial pressure, it can become to and fro pattern. And coming to the intrarenal vein, we stress intrarenal vein because we want to do Doppler of the vein inside the kidney, that is interlobar vein, not the vein outside the kidney or the main renal vein, because kidney itself is like a closed compartment. It's an encapsulated organ. So when you have venous congestion and subsequent interstitial edema, it's the veins inside the kidney that are feeling the pressure or the congestion. So with the so because it's a closed system encapsulated in a capsule, it's like portal vein. So below the baseline component is a renal venous pattern, and it's continuous. Above the baseline is the arterial waveform. And with increases in right atrial pressure, it becomes more and more pulsatile. And you see distinct S and D waves with further increases in right atrial pressure, very similar to that of hepatic vein. And similar to hepatic vein, with further increases in right atrial pressure, the S wave gets reversed. We are not just seeing here because it's embedded in the arterial waveform, but only D wave remains below the baseline. So whenever you are seeing this D only pattern, whether in hepatic vein form, vein waveform, or renal venous waveform, you are dealing with severe congestion. It can be overwhelming at first, so I'm just showing portal vein in our patient and not showing all these things. So going back to the portal vein in our patient, now it shows to and fro pattern, which means the patient has severely elevated right atrial pressure and also organ congestion. That's what this portal vein is telling you in addition to inferior vena cava. So we started this patient on diuretics, didn't respond well, eventually needed ultrafiltration. He underwent amputation. So this is how portal vein transformed. And this is how the patient, remember the patient was breathing fine, there was no significant pedal edema, lungs were sounding okay, but had horrible venous congestion. And this pulsatile, so this portal vein here shows to and fro pattern, and on follow-up one, there is no below the baseline component. It's slightly better, though it's very pulsatile, it's still severe congestion. And further follow-up, it's wavy, but much better than follow-up one. And during follow-ups 3 and 4, the portal vein has almost normalized. That way it gives us some objectivity as to what we are measuring or how we are monitoring the congestion in hospitalized patients. And this was the IVC, like this was the initial IVC on the right hand side. This is a transverse section. Initially I showed you long axis, and in transverse section IVC is usually elliptical and smaller than the adjacent aorta. Here is the aorta. But in this case, it's bigger than aorta and big and round. That itself will tell you that the IVC is plethoric. And here at the time of discharge, the patient's IVC has become like a slit, and here is the aorta. You can compare the size. So the patient was completely decongested, and the patient was off dialysis or off ultrafiltration at the time of hospital discharge. And here is a second case. And here is a patient who was admitted for some heart failure related admission. The patient's fluid balance was net negative 7.5 liters during the admission. So everybody was happy. The patient was relatively asymptomatic, wants to go home. And I did physical examination, that is point of care ultrasound. So looking at the lung ultrasound, you see here, this is the bright pleural line. These are the rib shadows. Here you see vertical lines like sun rays arising from the pleural line. These are B lines, which means the patient has significant pulmonary congestion. Remember, I showed you a study where the discharge day pulmonary congestion predicts readmissions. And not only that, looked at the portal vein, it shows to and fro pattern indicating severe venous congestion, as we saw in the previous patient. And unfortunately, everybody was telling the patient that you're doing well, we'll discharge you. So the patient made up her mind that she would go home, despite me telling that she was congested. And we arranged for a sooner nephrology follow-up visit in 2 weeks or something, and the patient was discharged. But unfortunately, she was back in 3 days and required an ICU admission. This time she got ultrafiltration for a few days, and this was a portal vein at the second discharge. And the interesting thing is that at the time of first discharge, there were 2 subspecialty notes. These are real notes from the patient's electronic medical record. They say lungs clear to auscultation bilaterally. There is bilateral leg edema, but continues to improve, and the weight is well below admission weight. So sometimes we just get carried away by the documented weight and I and O, that is intake and output, but these are not always necessarily accurate. And being able to visualize physiology at the bedside using point of care ultrasonography helps. And third case, there is this elderly woman with CKD, heart failure with preserved ejection fraction, and some terminal malignancy who was admitted for worsening fatigue. And the patient was not eating well. And I highlighted that because when somebody says like the patient is not eating well or drinking well, we just assume that the AKI is because of volume depletion, which is not necessarily the case most of the time, because I mean some of us fast, and if you don't eat food for 2 days, you don't necessarily get acute kidney injury. So that's one common misconception. So the admitting provider has held diuretics because the creatinine was worsening. So initially the creatinine was 3.1, went up to 3.4. The diuretics were held, and the creatinine continued to creep up. And there is a discrepancy in the weight and documented net negative. And obviously you can assume that one of these is inaccurate. And the internal medicine doctor again thinks, could it be over diuresis? But again, basing on the fact that the patient was not eating well, and maybe initially it was pre-renal and now maybe there is some ATM, that's why it's worsening. But now we performed physical examination. And on the note, in the internal medicine notes, again said the same thing, lungs clear to auscultation bilaterally. And the nephrology note from the same day too, the person who did not do point of care ultrasound, they wrote the lungs are clear and no crackles. But the real physical examination, that is lung ultrasound, showed this. Here nicely you can see the pleural line and so many sun rays or B lines arising from the pleural line. Here is another zone of the lung showing the B lines nicely. And look at the IVC, it's so big and plethoric in the transverse view. And here is the pulsatile portal vein, more than 50% pulsatility. So basically this patient had severe pulmonary congestion and also systemic venous congestion. So we reinitiated IV diuretic therapy, but unfortunately this was a patient with terminal malignancy, so the patient was transitioned to palliative care, so I did not get a chance to follow up. And the last case, we have an elderly patient with heart failure with reduced ejection fraction, and the baseline creatinine was 1.2 to 1.4, and the creatinine increased to 2.6 from baseline, and serum sodium decreased to 127. And the internal medicine physician thought the patient looks dry, so they held diuretics. Why did they think the patient looked dry? because the legs were like this. This was a real patient, and absolutely there is no pedal edema. So most of the people don't even really examine or measure the jugular venous pressure. That's why I said like we tend to overestimate our physical examination skills. And even then, the sensitivity of jugular venous distension is maybe 50 to 60%, not more than that. So based on this absolutely no pedal edema, dry skin, everybody were thinking the patient is dry. So we perform physical examination. So this is the long axis view of the heart. This is the left ventricle, and it's barely moving. The mitral valve is not opening that well, and that's fine. It's consistent with her history of heart failure with the reduced ejection fraction. This is a short axis view of the heart. This is the left ventricle. This is the semilunar right ventricle, and left ventricle is contracting, but not as much. So look at the inferior vena cava. So inferior vena cava is plethoric, more than like it's about 3 centimeters close to, and here is the scale. And in the short axis view also, you can see it's big and round. That is, we got a plethoric IVC. So just don't judge a patient by looking at presence or absence of pedal edema. And now look at the hepatic vein. So it's only D only pattern. That means there is venous return only during diastole, or there is only D wave here. That means severe congestion. And portal vein, 100% pulsatile with flow reversal, severe congestion. Intrarenal or renal parenchymal vein, again, it looks similar to hepatic vein with S wave reversal and D only pattern below the baseline. So all these 3 veins are showing severe congestion or severely elevated right atrial pressure. And this is how the patient, all these waveforms changed with IV diuretic. So the initial question was, is it over diuresis or should we give fluids, right? So initial sodium was 127, creatinine was 2.6. So we said initiate IV diuretics. This patient is severely congested. And follow-up exam, hepatic looks similar, portal vein also looks similar, and the renal also looks similar. So then we said congestion did not improve significantly, though the sodium and creatinine have improved. Sodium improved from 127 to 132, creatinine went down from 2.6 to 2, but despite improvement in labs, we said congestion is not improving, so continue IV diuresis. Why do we say IV diuretics? Because portal vein pulsatility likely indicates gut congestion, so oral diuretics might not work well. And after that, subsequently, sodium improved to 135, creatinine further improved to 1.7, and now nicely the portal vein has become continuous, completely normalized. I think the duration, the time lag between each of these examinations is approximately 2 days. And in hepatic vein, you have both veins, systolic and diastolic veins below the baseline, but the systolic vein was slightly smaller than the diastolic wave, which is mild congestion. And in renal, magically now both systolic and diastolic waves appear below the baseline. Here you had only diastolic wave. And here, further follow-up, sodium has almost normalized, creatinine went back to baseline, portal remained continuous and normal, and hepatic has normalized with S more than D pattern. And this is S wave because it's following QRS complex. And renal still has biphasic or distinct S and D waves, but renal little bit lags behind because of interstitial edema, so it takes a few days to completely improve and become like continuous pattern. So this is how you can not only diagnose congestion, but also monitor response to therapy. And just one slide about POCUS program development. Whenever you want to develop a POCUS program, it's important that you identify some faculty champions. I said nephrology division here. These are paper in a nephrology journal, but in general, in any department or division, you need to have like 1 or 2 or more, depending on the size of the program, faculty who are willing to spend time and energy in learning POCUS and also teaching POCUS, because most of us are not really trained during medical school or residency, so we need to learn POCUS first. And then identify experts within the institution who can provide guidance. So radiologists and cardiologists are not our enemies. They should be POCUS friends, and they are a tremendous resource in addition to emergency medicine POCUS director. If your institution has well-developed emergency medicine point of care ultrasound program, and you take help from all these people, and that way they can provide help with drafting the guidelines and the plan of action, and then get the ultrasound equipment that suits you depending upon the budget, and also depending upon the sonographic applications you want to do, whether you want to restrict yourself to very basic indications or you want to do more advanced Doppler stuff. And then set up the image transfer and archiving. You never want to do phantom scans. Phantom scans means you do some scan and just walk away. You tell your finding, nobody knows what you really saw. But you always want to save the images. That way they are documented. And when you are in doubt, your expert physicians such as radiologists or cardiologists can review your images, or even your colleagues can review your images from the previous day if they're following up on your patient. So always image archiving and transfer process is really important. And then you set up a designated training room or use simulation laboratory of your medical school to train your fellows and start training fellows, and the faculty should improve their image acquisition and interpretation skills by attending further courses and train other faculty in the division. And then finally establish a quality assurance program, because that's also very important for sustenance of a good program. And when somebody attends an ultrasound course, they, like just after they come out of the ultrasound course, they say, I know everything about ultrasound. That's called, this is called Dunning-Kruger curve. This is a well-known thing in psychiatry or psychology, where it plots confidence on y-axis and competence on x-axis. So initially, this is called peak of Mount Stupid, that the person's confidence is very high, but the competence is low. And eventually you learn more, and then you think it's more complicated than I thought. And then you reach a valley of despair and think, I'll never understand this. Then again, you start learning more, keep practicing, and then things start to make sense. And finally, the guru or the ultimate authority says, feels that it is still complicated and there is more to learn. And interestingly, the confidence level of this authoritative person is still lower compared to the person who is on the peak of Mount Stupid. So if you don't want to fall prey for this, there has to be a longitudinal curriculum and longitudinal quality assurance and growth of the program, and not just one-time time investment. And there are basic certifications available. You get your local certifications, and there are advanced certifications available if you're savvy about echocardiography and further Doppler applications. In US, we have National Board of Echocardiography certification for critical care physicians, where you can do all this hemodynamic stuff. And there is so much online content, educational content, including my website, nephropocus.com, where I periodically update posts, and I have quizzes, I have advice on program development, and so on. And Twitter is also a nice resource. As many people think, Twitter is not just some entertainment thing. There is a whole different world called Med Twitter, which means there are several educators on Twitter who talk things about POCUS, share interesting cases and stuff. So you follow these hashtags: POCUS, VEXUS, meaning venous excess Doppler ultrasound, IM POCUS is internal medicine POCUS, or just ultrasound. So you follow these hashtags, and you'll find a way to learn from Twitter. And finally, I'll finish with the quote: "A fool with a tool is still a fool." You can have all sophisticated instruments and bedside diagnostic aids, but if you don't know how to integrate the data you get from these bedside diagnostic aids, you remain essentially a fool. Nothing is going to be changed. So thank you so much, and happy to take any questions.
Thank you, Abhilash, for this excellent talk, and hopefully this will be a catalyst for more discussions in our hospital. And I see that Dr. Moheb has a question. Thank you for this excellent lecture about NephroPOCUS. How do you do quality assurance and quality review in your in-house program?
So, in in-house program, the fortunate thing is that nephrology is relatively a small program, right? So we have 3 + 3 fellows, the total of 6 to 8 fellows at any given point, not more than that. So the number of people is relatively low. So initially we have some goal, like they have to do 10 supervised scans in each sonographic application, and then they can do scans on their own, and then we can, or the ultrasound faculty can interpret those. And all our scans are saved, meaning we do clinical scans, which means clinically indicated scans. They go to the electronic medical record. And we also do educational scans for the fellow's education purpose. And they are saved in a different folder in the PACS or the picture archiving system, which can be retrieved for quality assurance purposes. So because the program is small, I review each and every scan performed by any nephrology fellow till they are officially certified in general. And also all the official report I write, and there is another POCUS faculty who write. So that's how quality assurance goes. And that's within nephrology. And out of nephrology, we have emergency medicine POCUS director who samples some of the studies, say every few months. They sample say 10 of the studies, say 10 of echocardiograms or 10 of lung ultrasounds, and make sure everything is going well and we are not missing any major findings. Yeah, it's always good to take the help of the people or the specialty who perform POCUS or perform ultrasound, whether it's radiology in your hospital or emergency medicine point of care program. So you need some help. Hope that answers the question.
Thank you, Abhilash, for this excellent talk. And I know we're running out of time. And Abhilash is on NephroPOCUS on Twitter and Instagram. So he responds to DMs. And I'm happy to share his email to those who are interested to get in touch with him. Thank you, Abhilash, for waking up so early in the morning to give this talk. And thank you, everyone, for joining in. You all have a good day ahead. Bye-bye now.